Welcome to Subcut, the medical-ish podcast where we talk about topics that are interesting if you're a high schooler or a medical student or a doctor or pretty much anyone interested in a field of healthcare. My name is Justin. I used to be a doctor.
I'm Emma. I'm a third-year physiotherapy student.
I'm Neil. I'm a fourth-year medical student.
Kia ora ana. My name's Georgia Whitta and I am a sort of fourth-ish year student doing research, no raratonga aho, and my family name is Tipiretu from the Cook Islands.
Kia ora ana. Tēnā koutou katoa, ko Coralie Takuira aho, no Pangaru aho te taho tōku pāpā, ko Pangaru te maunga, ko hokianga te moana, ko ngā toki matawhaoroa te waka, ko te raroa te iwi, ko Ngāti Manua te hapū. My name's Coralie Takuira and I'm a doctor onto my registrar training years.
And if you haven't figured out by now, we've got some guests on. They're not the normal Neil and Emma, us
Moving past that now.
boring old trio. The topic that we're talking about today is one that's been requested a couple times, which is why we've got our guests today. And the topic is around medicine, medical school, specifically around the context of Māori, getting into medical school with Māori background, and all the cultural things associated with that. Now, I know that not all of you listening here are from New Zealand. So if you're not too familiar with that, long story short, New Zealand, like a lot of other countries that were once upon a time colonized, has an indigenous population that still lives in the country and was incredibly marginalized by the colonizing party. Fast forward a bunch of years, it caused a lot of problems. There are still problems. And New Zealand, frankly, compared to the global community, is actually dealing with it a lot better than in other countries. But if you're listening in Australia, if you're listening in the US, a lot of the topics, a lot of the themes that we're going to be talking about is going to be pretty much the same. A lot of the challenges will be very similar in terms of concept. But this is going to be a really good one for our New Zealand listeners who want to just get a deeper understanding of something which is fundamentally a part of New Zealand culture, New Zealand fabric, and just getting a better understanding of that. So let's jump in a little bit, just starting with your background in a little bit more detail. Georgia, do you want to start just telling us about kind of the beginning of this whole kind of journey for you entering into medicine? When did the first thought get incepted in, and then how did that kind of, grow?
Right. So I'm Cook Island Māori on my father's side, and my father was born in Niue Island, and our family is Cook Island Māori, moved to New Zealand, as many Pacific Islanders do, for education, for jobs and stuff. And my father went to medical school in Auckland. So my dad's anaesthetist down in Palmy. And so I started loving medicine from when I was like 3 years old. And I wanted to be a doctor ever since I could first talk. My first big book, my dad got me a massive anatomy book that I used to study when I was little. So always loved that idea of medicine. And my dad's uncle, he was also a doctor in the Cook Islands, one of the first Cook Island doctors there. So yeah, I had that environment with me when I was really young and sort of really found a passion for getting into medicine and really making big changes when I went to the Cook Islands one time. And I went with my grandma Wawa to one of the clinics there, and just seeing the stark difference in the Cook Islands, with healthcare versus what New Zealand has in healthcare. And from that, recognising there's a lot more to medicine than my love for science, because that's kind of what started it. And yeah, luckily I knew exactly what I needed to do in high school in order to get into medicine. I loved science and all that stuff. So yeah, that was sort of my journey with it all.
The beginnings of it, at least.
Yeah.
There's so many points I already want to jump into that, but we're going to hold off. Coralie, do you want to give your background?
Yeah, sure. So my beginning is quite different actually. So I remember when I was little, I'd used to play with the animal soft toys and smear ink on them, red ink, and then bandage them up. And I've got no one in my family that's a doctor or a nurse. I'm not actually sure where that started, but I kind of knew from quite a young age that I wanted to be a doctor. But also at that time, there was sort of less awareness of what careers you could do. So at our school, I went to all Māori high schools, you know, you'd sort of be a teacher, a doctor, a nurse. You know, some of these things were just words that were thrown out there that's quite desirable, that if you could become that. So I'm like, okay, well, my grades are pretty good, so that means I'll go for the doctor. But I didn't have any role models or anyone in the science field, so I actually went to my mum's GP to ask him how you go about getting in. And so he gave me advice, you know, you need the best marks possible. What are you good at? And I was good at painting. So actually I did mostly arts, painting, design, all that kind of art. My mum's an artist, and so to get my marks up so that I could get into uni. And I knew, okay, I need to take physics and chem, and I wanted to do a human bio, but my school doesn't offer that because there's only 7 people in 7th form. So basically I had, very small school.
That's year 13.
Yeah.
Yeah.
So, you know, but again, that shows you the differences in academic inequity within Māori high schools. So if you want to pursue your language and your culture, but academically it's not strong, you know, or you're already starting at a disadvantage. So I knew, okay, I've got to take chem. So I did chemistry by correspondence on top of my subjects, but physics just wasn't available. So when I hit uni, in that sort of first year, pre-med year, I got friends to tutor me in physics. But chemistry, unfortunately, I failed. So that means it just wasn't an option to get into med. So I had to finish my degree, became a scientist, did honours, and then ended up as a scientist for 4 years. And then down the track, you're kind of like loving earning money. But my professor, he's very supportive of me. He's like, okay, it's time to do a PhD. And I'm just like, how did I get here? I'm sorry, but I'm actually on this journey to do medicine. So that's when we planned ahead, and I went from being a scientist back to uni again. And luckily with every year my marks got better because you know how the university system works and how to study. I literally didn't know how to study when I got to uni and how to write good essays. Some of the feedback was so harsh from the tutors. They're like, oh, anyway. And so I got, every year got a bit better, my marks, and by the end I got first class honours. And so thankfully that got me the A pluses I needed to get into med so I could start that journey.
Wow.
A little bit of a longer story.
Yeah.
How many years was that since graduating high school?
Yeah, it was 5.
Right.
So, and then plus med, it was 10 years.
10 years that you were at uni. Did you work after doing your honours?
Yeah, so I worked for 4 years as a scientist, and that was really good as well because I was quite young.
Yeah.
So it gave me a lot of skills like doing presentations, having the confidence to talk in meetings around New Zealand and publish papers. So that all really looked really good on the CV. So there were lots of benefits to that as well. And then my topic is diabetes and cancer. And diabetes is a huge issue for Māori, so it's kind of come full circle for me. So I'm really grateful for that knowledge anyway.
So it was 8 years since high school that you entered into medical school, is that right?
At least, probably 9. I finished high school at 16, so again, I was probably a bit young.
Okay, so one of the things that I really want to know is, for both of you, how common was the idea of kind of, you both said that you had the idea of wanting to be a doctor, and obviously Georgia, with you had that kind of background in your family. It was in a way like normalized in your family at least.
Yeah.
And Coralie, you were quite different because you didn't have any medical people. You said you didn't have anyone to really. So how normal was that, even just within your peer group at least, to kind of want to do medicine?
Well, so in my high school, there was only 4% of my high school was Pacific Islander. And so it was, a very interesting experience. And it was really, really shown to me that the standard that my parents held for me academically was very different to the standard that my teachers and fellow papa'a Pākehā students had about me. So in my household and within my kōpū tangata, within my family, it was normal. But in high school, it was met with a lot of surprise, a lot of questions, a lot of doubt. And fortunately, I had a really close friend who's Samoan who also wanted to be a doctor. And so her and I really clung on to each other throughout high school because, it was, and it was different. It was kind of difficult for me to have those experiences from the household that I'd grown up in where it was never questioned. It was just like, yeah, she's going to be a doctor. So that was my experience. High school was a difficult time.
Yeah, in high school, I felt that being at all Māori high school, some of the teachers had sort of already given up on us and had quite low expectations of what we could achieve, but they could see the drive in me and another student there who's also now a doctor. So we both knew we wanted to get into medicine, and thankfully she was really good at chemistry and got straight in. And she's now a GP, so that's so awesome that our school, from our 1 year of 7 people, we've made 2 doctors. But I'd say a lot of it's not just the school. It's like a lot of your family supporting you. So my mum is educated. So what I like learning at uni is that we have these different protective factors. So even though we may have different disadvantages, we also have other privileges which protect us and help us get to where we are. It's not solely by ourselves alone. So although Mum's not medical, she did have the awareness that, I needed to pursue education so that I wasn't a struggling artist trying to feed the family. She's like, don't do art, whatever you do. I love art, actually. Yeah. So I had, her name's Ihipera, and so we were very competitive actually because we both wanted to be ducks. So that actually just drove us harder and harder, and we got joint ducks in the end. But so here I am thinking, I'm going to go into uni. But when I got to uni, the ducks are way above. So I'm ducks of 7 people, sure. But when you get to uni, it's a whole new level.
So just for anyone who's not familiar, ducks means first in your school of your graduating year.
Yeah.
I was just going to say, and correct me if I'm wrong, but I think one of the things that Justin was getting at with that initial question was that, in my experience, Mori and Pacifica, because they don't have those role models, and as well as because of the oppression and all that's gone on when they sometimes there's obviously an over-representation in lower socioeconomic areas. It's like a foreign idea to be into healthcare for some of the Maori and Pacific people that I've met. Is that do you get that way, that it's sort of like they don't have those role models? So
well, 2 things. I'll just be careful with the wording about saying Māori and Pacific don't have those role models. Always start with some Māori and Pacific peoples do not have those role models because it's doing too much of a generalisation. It's just that I get that a lot in the hospital, and so if people want to apply something, just always put some in the front. And it's not necessarily a foreign idea, but it is true that if you don't see people like you within that setting, you don't know what's attainable. And so, for you having those role models, you're like, well, of course that's achievable for me because it's been done. My family's done it. So, and that's the point of having adequate and appropriate representation of Māori and Pacific peoples within the healthcare setting, so that it's not only normalised, but we have these role models and they're like me, they understand my culture, they don't, sweep my thoughts aside in the way that I do things. I'm actually boosted. And so not only do we need to get to 16% for Māori as a representation, but we need to go beyond that because of the inequities. So to reduce inequities, all doctors are going to have to understand the causes, the upstream causes, but then we also need that representation.
And I think that it's a lot, not necessarily like Pacific Islanders it's just reinforced by everyone else that it's not a place that we belong in. We don't belong in academic success. We don't belong in hospitals. And for me, that was an idea that was reinforced by teachers and peers. So it wasn't necessarily that, like, from home I didn't have the role models. It was what everyone else was saying, where I belong in like this society. I don't belong in academic and I don't belong in the hospital.
I really feel, because I get the chance to work with a lot of Maori and Pacific students, more Pacific actually than Maori with the schools that I tend to work with. But I do often find, not always, but I do often find that some of the biggest barriers is actually trying to convince the teacher that setting such a low standard is not going to really help. So I'll come in and I'll say, look, you have a class of 30 students. You have 30 driven Maori and or Pacific students who are keen to enter a field of healthcare. I'm coming in there saying, like, you can do this, we can build up the skills, you can actually have a decent chance. And they're saying, like, oh, look, let's just focus on getting some passes, you know, in there. And it's like, okay, look, it's all good that you need to meet your whatever quota of passes, but just having that entire mentality is just so detrimental. And I actually see a noticeable difference in the schools that I work with where the teacher is supportive. I mean, there's a really clear outcome difference. You know, some schools where they don't have that support, they wouldn't have produced a doctor in 20, 30 years of generations of students. And some are producing, you know, a doctor, you know, every year or, you know, so I think it makes a really big difference.
On the topic of representation, Coralie, this is really weird. Here we go. On the topic of representation that you were mentioning before, I know that both of you are quite active in your own sort of ways and throughout your whole experience, trying to aim towards better representation in the fields that you're both in. Could you guys talk a little bit more about that? Maybe you could get a better idea about what both of you are into right now and what you're up to. Yeah. So
personally for me, I had been working, not so much now, but I was working with NZQA and NCA as a Pacifica STEM ambassador. And what I was doing with that is we were going into high schools and we did one amazing session at Wesley College, and we went in and taught science to students. And that was one of the best things I've done. They had, they showed us the stats, and where in a test they would be lucky to get, you know, I think it was 10 students turning up to their exam. After our session, they had 70 to 80 students turning up. And it was just the same idea. Yeah, it's what we talked about is that we went in as teachers and believed in them, and we weren't just saying, oh, like, these are how you get your A3s and A4s. We were like, you know, these are how you get your excellences. And that was one of the best sessions that I'd had working in that job. We also were working with the digital team for NZQA, who focus on digitising all the NCA exams and making sure that they were doing it in a way that wasn't going to be detrimental to our Pacific community. I mean, with, you know, access to computers, with computer competency and stuff. And then now, from last year, I was working to get a Pacific role on Auckland University Medical Students Association, UMSA, and that's like an advocacy role within the medical school to make sure that we worked on a Māori role to make sure Māori and Pacific students are being represented and heard. Yeah, that was another challenge within itself. And I work with MAPAS, the Maori and Pacific Admission Scheme, as a tutor in a tuakana, trying to get first-year students into medical school with biology tutoring. Yeah, I think that's what I do. I also work with the medical school in teaching, so teaching labs and stuff like that, and trying to be a brown face in those labs, so our Māori and Pacific students feel a bit more comfortable approaching a tutor.
Nice.
And that is my CV. Give me a job.
yeah, these two people on the left of me are like beyond impressive, to say the least. Like, but yeah, amazing, cool.
Just different journeys.
Yeah.
During my med school, I didn't actually get the opportunity to do these extra things because I was kind of just wading through it, just trying to survive myself. I was fortunate to have a tuakana mentor, which was great. And I'm not sure if we did much else and meet up for coffee, but even that was nice to know that she's a couple of years ahead of me and these things are attainable. She's, you know, comfortably going through university. So all these little things in your life do help. I did apply for the tuakana role, but maybe my grades weren't good enough. Throughout medicine, I'd say mine's more with as being a doctor. So because there are not enough of us in the healthcare setting.
Can you give some numbers actually? Do you know any numbers off the top of your head?
No,
What that underrepresentations?
So the goal for 2020 for the Ministry of Health was to get 10% representation for Māori in the public health force. So that's nurses, doctors, physiotherapists, OT, like all across the board. But the stats, so all the stats are a bit delayed because they're collecting the data. So sort of from the 2017 to 19 range, we're only at 3%.
Jeez.
And so we're already at 2020 and have not achieved that. So when I get the chance as a doctor, because my audience is going to be other doctors and people working in the healthcare setting right now, I make sure to have a kaupapa Māori. Basically, it's all about Māori. And I'm like, am I being biased? I'm like, no, I need to reduce inequity. So I'm going to get every opportunity I get, I'm going to teach these people who are on the front line doing the work and maybe being able to change how they act. So whenever I give talks within the hospital, as we have to do as doctors and keep sort of up to date and evidence-based, I make sure it's relevant to their field so that they can see how inequitable their field is. So my recent placement, loved it. I requested renal medicine and I thought, Auckland City, I won't see that many Māori here because in the central city, the representation's about 8%, even though 24% of all Māori live in Auckland. So I was like, I won't see many Māori Pacific Islanders, but the opposite was true. Most of the ward was Maori and Pacific, and this is end-stage renal failure. So your kidneys are literally about to give up on you, and of course you'll die if you don't get renal replacement therapy. And so 70% of both Maori and Pacific patients, their primary cause of their kidneys failing was type 2 diabetes. So this is a preventable disease. And so on the ward, I'd see women, she just had her baby, she was 20 with end-stage renal failure. This is so unacceptable. How much shorter is her life going to be? Because you can only be on this replacement therapy for X amount of years, and then you need to go to next steps. And there's a lot of complications, a lot of medications, a lot of visits, and a lot of DNAs. When people can't come, it's like, their life is hard.
So
they've got a lot. Did not attend.
Yeah. Tell me a little bit. Let's talk about DNA real briefly.
So I had to do clinics, and being a health officer, they gave me less so that I could spend more time with the patients, educating them about how kidneys work and their new health condition, which is great. Loved having that extra time. But I'd read up ahead in my Māori patients. I was like, great, they can see a Māori doctor. And she did not attend. And I was like, damn, because her previous one, she didn't attend. So I tried to give her a call and I told the nurse. I honestly wanted to drive because we have their addresses. I was like, maybe I'll just drop in. So I told the consultant, I was like, what do we do? I need to get this info to her. Her kidney's about to die. And, she's like, unfortunately, we have to discharge her from the service. And she has to go back to the GP, wait again to get in line to the specialty. I'm like, I think she's going to present to ED faster than that happens. And there's a lot of issues. It's not just she didn't turn up. It's like, did she have transport? Does she have a newborn? Does she have issues at home? does she have other addictions? There's so many facets of a person's life that prevents you from getting to an appointment which you're not really sure what's about. You know, if we haven't taken human bio at school, do people know what a kidney is? And I know a lot of my patients did not know what a kidney is. So how do you know to save your kidney? Like what that doesn't sound very important, you know? And then I've had so many experiences where the consultant was just like, not on renal, this is something else. They were excellent on renal, loved it. They're like, don't drink beer, don't have salt, your kidney's going to die, you know, just like telling the patient off. And it was a consultation and he left. And I was like, do you know what a kidney is? And the patient's like, no. I was like, okay, I'll finish the ward round and I'll come back. Don't leave. You know, it's just like, get the basics first. Yeah. So a lot of experiences like this.
I think it's really hard for people that haven't grown up with that background to even consider that this is what the patients are even thinking in the first place. You know, if you've grown up around like just highly academic people all your life, and then, you know, everyone knows what a kidney is, and then you know, you don't show up your appointment a few times, like, well, like it's your own fault. You know, it's easy to have that mentality without really thinking about like, well, you know, would you ever attended the appointment on like a bad day for you? Or maybe, you know, your bad day is like a normal day for, you know, this person where they can't, you know, get to transport. What, you know,
their bad day would be traffic, or my kid threw a tantrum this morning. Like perspective matters there as well.
I think just quickly, two other things regarding that. So with these patients with end-stage renal failure, they also have less opportunity to get a kidney replacement. So our ward was sort of divided in two, and on this side is everyone who got to receive a new kidney, and so they switched drugs and the outcomes better. They've got a functioning kidney to clean their blood, and it was mostly Pākehā. And that was big. There's really multifaceted, but also, you know, there's majority of people are Pākehā, so there's more kidneys to donate. But then when there's more comorbidities within the patient, they're not eligible to then get that transplant.
So comorbidity means other diseases that the person would have.
And then within the wider nation, if there's more comorbidities in Maori or Pacific people, then they're not eligible donors, so there's a lesser pool of kidneys. So there's just so many barriers. And then the other one regarding did not attend, it's not that the individual is so broad and so systemic with so many long-term effects from colonisation and into poverty. So some people are a bit condemning of individuals when they haven't thought of the broader picture and how do people get into that position.
Yeah, it's like we learnt about it a bit in medical school with a deficit framing approach that's taught in our Haura Māori program, and it's the idea that a lot of systemic issues and things that have happened because of colonisation of Aotearoa and the impacts of all that is people tend to blame the individual rather than blaming the system that placed the individual where they're at right now. And that's one thing that I think is really detrimental to our Māori Pacific patients is we are seen constantly, or we get described as in medical school as, you know, we're the difficult patients. Like your Māori Pacific people are going to be the ones who don't attend appointments. They don't know what their medication is. They came in eating KFC. They don't speak English. Like there's just so many stereotypes that in medical school are taught and reinforced. And then I mean, like when we learn about Māori Pacific people, it's, you know, it's just their health inequities. You don't learn anything else. And so then doctors treat Māori Pacific patients a certain way because that's the way the medical school has enforced it. And, you know, the hidden curriculum being how doctors, when you're like in placement, how doctors treat Māori and Pacific patients and, you know, the stereotypes that they constantly reinforce. And it makes it hard to, you know, hear that about your people constantly. And, you know, just even with clinical scenarios that we get, it's just always the same rhetoric about our people.
And I think that's, again, the thing when you use the word some in front of it. So although there's an over-representation, it's to remember that every person you see is completely different individual. So if I was in a gown and then before they come in to see me and it says, you know, Māori, for them not to have immediate thoughts, oh, smoker, drinker, da-da-da-da. And because you've taken these clothes away and you've taken a bit of respect and mana away from the person, so you're judging them due to these unconscious biases, which are sometimes quite conscious.
So you just mentioned the word mana, and we've got an international audience. Can you just give a quick
Do you? No.
We do. We've got thousands, maybe even millions.
I didn't know that.
We'll go worldwide.
Mana is like the prestige that you hold within yourself. So someone can be born with mana. In earlier times, it was quite obvious, you know, if you're a chief, you have a mana that you're born with, sort of like a nobility. But you can also gain and lose mana. So things that you do, you know, it might be for your people, or in the past it would be battles that you've won will gain you prestige. But you can also defame your name and lose mana. So people can do things to you that try and sort of belittle you and suppress your mana. So yeah, the word is kind of like a prestige, or just how you hold yourself as well.
I just wanted to go back to what you were talking about. I've seen it happen twice in terms of, you know, the group of surgeons or the doctors would come gather around and they'll have a list of patients on regarding maybe some sort of organ transplant, or seeing whether they're, you know, fit to receive it or not based on all their comorbidities and their progress, because this wouldn't have been the first clinic that they've you know, visited, and so the doctors will give them some sort of advice saying, you know, if you want to proceed with this operation to make you better, you're going to have to reach these points and these sort of deadlines by this time, and then we'll bring you back into the meeting and we'll see how it goes from there. So that was a new sort of thing to me. It's my first year in clinicals this year, so that was cool, but it's ridiculous, and I still find it so surprising that, like, sometimes if you're not actually looking for it and listening for the decision to be made, it's almost as if they're just having a normal conversation, because it's a thing that happens regularly. But it's like, to think that that's a person's life, that it's just sort of like, didn't meet the quota, sorry, we can't do it. Next one, who's next? Yeah. That's the sort of tone that was at. But I also do notice, and I can't, you know, you can't blame the person over here itself, even in terms of the doctor. It's, well, not entirely as well, but like, there's a sense of defeat and even in the doctor's voice as well when I hear them say, we can't do anything. Partial sense of disappointment, saying, you know, like, you didn't reach it, damn it. The other side is also like a sense of defeat there, that, like, you know, we told you that you need to hit this, but you didn't. But I don't blame you entirely either. I think doctors are improving now compared to back in the day, at least. Well, not that I know back in the day what it's like, but, you know, they are improving in terms of their cultural competency in that way as well, and trying to, you know, just be a bit more aware about the other things that would affect, or, you know, like the access, like everything really that means that they won't actually be able to meet those deadlines and those, you know, those goals.
Yeah.
Can I make a quick comment? So when I was in high school, right? I mean, I didn't have pretty much any Maori or Pacific friends. There was probably like 3 in my whole school, honestly. I grew up, you know, learning about Treaty of Waitangi and Māori health, or Māori inequities in general, from social studies or social science at school. I hated it. It was my least favorite subject. I thought it was boring. As a result of that, I thought the whole topic was just very, I had a very blasé attitude about the entire thing. I think a lot of students are like that, that don't have the kind of ingrained background. I learned about most of this stuff in university through courses, and then I gained more knowledge on that through medical school. And then we have got all that cultural competency training through medical school. We've got, you know, University of Auckland has Māori Health Week, which tries to sort of intensively cram like an entire culture in 1 week. And then you work as a doctor, right? And you work as a doctor, and you get continued sort of this education opportunity like that. So I feel like I've undergone a certain transformation in terms of my understanding. I feel that my knowledge and real understanding of culture and cultural competency was absolutely nothing compared to when I actually started for educational work, going into schools, talking to students, working with students, talking to whānau, seeing what it's actually like, talking to the teachers and the principals. I think, to be totally honest, this is my freaking podcast. I can say whatever I want.
Also, your opinion.
I think that the way that we're taught cultural competency in medical school is incredibly tokenistic.
Yeah,
I really think
is.
that
Yeah.
it
Hoping we're going that way.
underdoes it. I felt that I was at no point very well prepared to deal with the challenges in a meaningful way for my Maori or Pacific patients. There are multiple times where I saw patients and I thought, you're basically going to die, imminently or just close to imminently. And for some reason, like, I just cannot communicate that. Like, there just seems to be some kind of barrier. Literally, someone who's about to have a burst ectopic pregnancy, which means that the baby is implanted somewhere it shouldn't be, and if that's basically life-threatening. We did an ultrasound scan. We were like, this person is about to have, has an ectopic pregnancy. You need to get an operation now. And then she left because she was hungry. This is not a person that's just so stupid or suicidal. It's just someone who just clearly didn't have the kind of health, communication, background, literacy alignment there for it to click that actually, like, this is some serious stuff. I need to have an operation, and that alignment. And, I did all of medical school and it just never really settled in.
Up until recently, I'd used that term as well regarding that person's health literacy, and it's true because we've all come from different backgrounds and we don't even have to finish school, so you can leave at 15 and you've got such minimal exposure to biology. It's probably the only compulsory subject. But so it's another podcast by Emma Espiner. Has anyone listened to that one? Oh, it's great. And she highlighted it to me. So she's a medical student right now and also a writer, Maori med student. She highlighted within a podcast I listened to recently that the health literacy is putting the onus on the person, rather than us saying that we didn't appropriately convey the knowledge that we have and been trained for years. And now we're trained to give that knowledge to lay people, so we didn't appropriately pass on that knowledge of how serious it was. And if she didn't understand it, then we actually failed her. So it's not in her health literacy; it's our role to make sure that was clear.
It's like health educational competency.
And again, when you work in the real system, we're so pressed for time. Like with all my patients, I want to convey this knowledge and teach them so that when they leave, you've had a tangible impact on their life so that they can implement these health changes. But you're so rushed off your feet. It's actually a systemic issue within funding for the DHBs.
And often to compensate for that, it's just, here's a pamphlet.
Oh, absolutely.
I've seen that as well.
I think we talked about this in a previous podcast, right? Where we said that basically informed decision-making is pretty much a myth because you never get enough time to inform them enough to make an informed decision.
And I guess with that issue is that when you're time pressured, that's when, as doctors, your biases will jump out. And that's when, your Maori and Pacific patients are going to feel it the most. And healthcare in New Zealand or in any sort of papa'a, Pākehā society isn't made to benefit Māori and Pacific people, and it's not made to benefit anyone but sort of our cis-het white community. And so I think that whole system and the way everything is set out that's why we have these things happening, and that's why you have patients who, when they have an urgent ectopic pregnancy, it's, that's why there's the dissonance. You can get so deep with it all. It's not just the health, it's everything.
I think an example for that, because people might listen and be like, equal opportunities to access healthcare, that's not inequitable. But so I think what you mean by when it benefits Pākehā. So, Dr. Nina Scott, she is a public health physician working in cancer. And so Māori are twice as likely to get different cancers, and then anyway, I'll withhold the percentages, but more likely to get get different types of cancers because there's other risks such as type 2 diabetes and lifestyle factors, but also die from the cancers. And so when we do health screening, for example, for bowel cancer, because of funding, we create age cutoffs. So if we screen everyone above 65, say, and then I want to target 70% of males, that will get a good enough pool for screening for bowel cancer. But what she proposed is like, well, Māori are getting this bowel cancer younger, and to get the same health mortality benefits that Pākehā do from the screening pool, we need to have a broader target for Māori. So actually screen more Māori at a younger age, and it was about at 55 because Māori have a 7-year younger life expectancy than non-Māori, which is huge. So she proposed this, but it's two tangible facts that she's just pointed out. To make it equitable for Māori, you need to lower the age of screening, because if they're dying in their 70s, 65 is too late, and they're going to die from the cancer.
So I'll just make a quick interject. So with the screening program, the point of doing a screening program is so that you can catch something early enough to actually make a difference. You're not going to run a screening program on people that got shot on the head, for example, because there's nothing you can do about it.
Screening for death.
Yeah, so the whole purpose of the screening program is to prevent serious complications from it. So but you're saying that it's too late to have that same age.
You have to change the criteria to fit the population, and especially if we already know the outcomes are inequitable. So to make it equitable, you need to change the criteria, but currently it just fits the majority of people. So she proposed that to the council, and they said, no, we won't do that. And so what happens is a knee-jerk reaction when it's like, we're getting all these Māori patients, with cancer, and what are we going to do? And it's like, you need to act earlier. But I think they're making progress this year.
Do we know why it was rejected?
Well, finances is a big thing, because to do something 10 years earlier with a bigger pool of people, maybe,
What if they would have? I mean, I might be speculating over here as well, but if you were to compare the cost of them coming into the system later, where the cost would be much higher to treat their condition that they've now got, because I think screening tests aren't very expensive. No.
Well, compared to hospital treatments.
There we go.
Much cheaper. I mean, lay people may not know, but hospitals are very expensive. A single night in a surgical ward in hospital can easily be $1,000 per night without even having received any treatments. If someone stays for a long time for like renal failure or bowel cancer, they get a big operation. That's looking at costing the health system $50,000 to $100,000 for that one person stay. Screening program, $200 for a person. I mean, it does pay off.